Parotidectomy. So this is also very important with respect to your exam, specifically the complications with a special emphasis on your Frey syndrome. So let's discuss the important steps in a nutshell. Now first important question that comes is right from the incision, which is your modified Blair incision, which is used for your parotidectomy. Right now, so if you see the steps involved, incising of the platysma on which you have the exposure of your external jugular vein. So this should be tried to be preserved during your parotid gland surgery. Then you have your subplatysmal plane dissection, where you come across your greater auricular nerve, which can be traced down to the ear lobule, and this should be preserved. Now the main crux in your parotid gland surgery is your identification of your facial nerve. Now the various important anatomical landmarks includes your tragal pointer or your cornless pointer. Now the facial nerve lies 1 centimeter deep and inferior to it. Now for mastoid tip, it lies proximal to it, and for the digastric muscle, it lies on the upper border of your posterior belly of the digastric muscles. So once your facial nerve is identified, we go for a centripetal dissection. So please just remember that identifying the main trunk, and then we limit our dissection above this main trunk to avoid any injury to your facial nerve, and then we ligate your parotid duct. So the facial nerve identification, as we said, 1 centimeter deep and inferior to it. In digastric muscle, you have on the upper border of your posterior belly of digastric muscle, and it lies inferior to your tympanomastoid suture, and it lies proximal to your mastoid. So these are your few important antegrade localization of your facial nerve. Your retrograde would be following your branch and following the various branches and identifying the main trunk of your facial nerve. And nowadays there is also the use of the intraoperative nerve monitoring techniques in order to localize the facial nerves. Now regarding your complications of your parotid gland surgery, it includes a hematoma formation, infection, deformity, which is unsightly scar and a retromandibular hollowing, temporary facial nerve weakness, or there could be a transaction of your facial nerve and your permanent facial weakness, yellow seal, facial numbness, Frey syndromes, and the permanent numbness of the earlobe associated with the greater auricular nerve transaction. So these are few of the important complications of your parotid gland surgery that you guys need to remember. Now we shall end this discussion with a small discussion on your Frey syndrome. So what is Frey syndrome? This is your gustatory sweating. It occurs because of your cross innervation of your dermal sweat glands by your regenerating postganglionic parasympathetic nerve fibers of your auriculotemporal nerve. Now sweating and flushing in the preauricular region occurs during meal. Now a minor starch iodine test identifies the region. Salivary stimulation turns the starch blue. So how can it be reduced? What intraoperative measures that you can take to reduce this Frey syndrome? By raising a thick flap with all subcutaneous fat over your parotid, and interposition of your tissue with the help of a flap, temporalis fascia, and allodermal tissue, and use of extracapsular dissection technique. Right, and what would be your treatment? Your treatment would be your tympanic neurectomy and your botulinum toxin injection. So please remember this Frey syndrome, especially your nerve involved is your auriculotemporal nerve. And how would it present? Your sweating and flushing in your preauricular region during meals. So this is your classical statement which is given in your clinical scenarios in order to help you diagnose your Frey syndrome. Thank you.